is pulmonary hypertension in the African American patient. The presenter will be Dr. Alem Mehari. Dr. Mehari is an assistant professor of medicine in the Division of Pulmonary and Critical Care Medicine at Howard University College of Medicine. She is certified by the American Board of Internal Medicine and has a subspecialty certification by the American Board of Pulmonary Medicine. After completing her medical education in Ethiopia, she interned in internal medicine at Howard University and completed a residency in 2006. After functioning as an emergency medicine physician in Washington's Veterans Administration Hospital for 1 year, she joined a fellowship in pulmonary medicine at Howard University. And upon completion of her fellowship in pulmonary medicine, Dr. Mehari completed a 2-year postdoc research fellowship in pulmonary vascular disease at the NIH, at NHLBI. And she studied pulmonary vascular diseases with special emphasis on sickle cell disease and complications. And upon successful completion, she joined the faculty at Howard University College of Medicine, where she currently practices as a pulmonary hypertension center of excellence. It'll be our pleasure to present her after we do our pretest. Pretest, please. Case 1. Patient Mary Brown profile, 35-year-old African-American female with sickle cell disease who was taking contraceptive pills for 5 years. History revealed her mother died in her 40s of symptoms suggestive of pulmonary arterial hypertension. She presents to you on her first visit following confirmation of her diagnosis at a PAH specialty center and the initiation of PAH-specific therapy. You're providing collaborative care in cooperation with the PAH specialty center due to the distance from the patient to the center. At diagnosis, WHO functional class 3 symptoms, 6-minute walk distance was 300 meters. VQ is high probability. Hemodynamics during the right heart catheterization, mean pulmonary arterial pressure at 45, right atrial pressure of 8 millimeters, pulmonary capillary wedge pressure of 5 millimeters, cardiac output 10 liters per minute, and pulmonary vascular resistance 4 Wood units. Which of the following should be a part of your routine follow-up with a patient diagnosed with PAH? Number 1 would be the 6-minute walk distance assessment. Number 2 would be echocardiography. Number 3 would be overnight oximetry. 4, BNP or NT pro-BNP. Number 5 would be the studies CBC, PT, INR, or Chem7. And number 6 would be all of the above. Please select now. Okay, good. Our next question, please. The patient appears to be doing well and says she's eager to participate in the family event and asks you if she can travel by air. What would you advise her about air travel? In-flight O2 supplementation recommended for patients, 1 patients with WHO functional class 3 or 4. Number 2, those with arterial blood O2 consistently less than 6 millimeters of mercury with oxygen flow rate to maintain SaO2 of greater than 91% at all times, assuming a cabin pressurized to approximately 8,000 feet. Patients should avoid going to altitudes greater than 4,900 to 6,500 feet without supplemental O2. All of the above, or none of the above if the O2 saturation is normal. Please vote now. Okay, so thank you for doing the pretest, and now please join me in welcoming Dr. Mehari.
Good afternoon, everyone. Thank you, Dr. Jones, for the generous introduction. And I would like to thank the organizers of this session for inviting me to talk to you all about this topic. It's really an honor to be here. This is my first time to be at the NMA, and just seeing you all, you feel at home. And not to talk about sickle cell disease in this convention is a miss, and the organizers select the right topic. So this is my disclosure slide. So let's talk about sickle cell disease as an introduction. This is a disease which is an autosomal recessive hemoglobinopathy. Can you hear us? Okay. So looking into the burden of sickle cell disease is the most common genetic autosomal recessive hemoglobinopathy. It occurs worldwide, but it occurs most commonly in sub-Saharan Africa. 85 to 90% of patients who suffer with sickle cell disease live in Africa. And to date, more than 2,500 children are born each year with this disease. So you can see how big the burden is in certain parts of the world, especially in sub-Saharan Africa. It also occurs in the Indian subcontinent, also in South America. In the US, it's estimated based on newborn cohort adjusted for mortality, around 100,000 patients live with this disease. Most of these patients are, of course, African Americans or of African descent. Sickle cell disease in the Western world to date are living longer. 30 years ago, most of the patients were dying before the age of 30. To date, with universal newborn screening, increased awareness, penicillin prophylaxis, most of sickle cell patients are living to adulthood. But they die younger, 3 decades younger compared to the US population without sickle cell disease. And if you look into this graph, the x-axis is age at days, and the y-axis is percent of survival. Sorry, you don't see it very clear. And these are 2 time periods. First, the dotted line is the time in the 1979, and this solid line is in the years of 2000. If you look into the dotted line, you see 2 spikes. You see the first spike, many children before the age of 10 were dying from this disease. If they survived this age group, they were dying in their early 20s. What we see in the solid line, which is in recent years, is the spike which was occurring in the first 10 years of their life has smoothed down, which is a big progress in this field. But when we see in the second spike, we see that we move it a little bit to the right, but we are at stuck in this. So that means that we have a lot of things that we need to do to smooth this line, because our patients are still dying very prematurely. And not only do they die prematurely, but they also suffer during life with many diseases that comes due to this disease. This is a national data. They looked into the causes of mortality in these patients. If you look into this closely, you see that cardiopulmonary complications account for almost 60% of causes of death. And when it comes to the respiratory system, acute complications such as acute chest syndrome, if they don't die due to acute chest syndrome, they develop pulmonary vascular disease. They develop pulmonary embolism as well as pulmonary hypertension. So in relevance to today's talk, I'm going to focus on pulmonary hypertension. So what do we know about pulmonary hypertension and sickle cell disease? So we have an echo data. We have an echo data which shows that if they have an estimated pulmonary artery systolic pressure is elevated by echo, they have worse survival. Most recently, we used a right heart cath to define pulmonary hypertension. If they have pulmonary hypertension, their survival is worse. They have 40% mortality at 6 years. And then another non-invasive test using MRC, we have very limited data, but we have a single data which I'm going to show you in the coming slide. If they have worse RV function, then they have a poor survival. Again, Dr. Polk and Dr. Kingslow were emphasizing our patients die with pulmonary hypertension, but they die because of right heart failure. And this is the echo data. So in 2004, the first author, Dr. Gladwin from the NIH, he screened patients at the NIH as well as at Howard prospectively in 195 patients, and he published it in New England Journal of Medicine. If they have sickle cell disease, a third of them have pulmonary hypertension. If they have pulmonary hypertension, they have 40% mortality at 45 months, compared to 2% of those patients without pulmonary hypertension. Again, this study was replicated at many centers of sickle cell center of excellence in the nation as well as internationally. To mention some of them, this is from Duke, this is from UNC Chapel Hill, this is again from NIH. If you look across all the studies, a third of these patients develop pulmonary hypertension by echocardiography. But again, this audience is, trained enough now at this moment that we cannot define pulmonary hypertension based on echocardiography. But all of them say, if they develop pulmonary hypertension, their survival is poor. 17% in 24 months with pulmonary hypertension, 2% without pulmonary hypertension. But again, Dr. Kingslow and Dr. Polk were stressing the pitfalls of echocardiography. And when it comes to sickle cell disease, there is a high false positivity when using echocardiography to diagnose pulmonary hypertension. For many reasons, because it is a test which is operator dependent. Second, sickle cell patients, they suffer from pain crisis and their crisis change from day to day. Pain, sympathetic activation, increase your pressures. And again, we want to re-emphasize, we cannot diagnose pulmonary hypertension until we do right heart catheterization. And when it comes to an individual patient, we cannot depend using echocardiography to manage our patients. So this has led us to dig further. And at the time when I was a fellow at the NIH, there was a lot of editorials and a lot of controversy written about sickle cell disease-associated pulmonary hypertension. If it is real, does it matter for sickle cell patients? And when I went to do my pulmonary vascular research fellowship, I was a board-certified pulmonologist. And when I went to one of the scientific meetings, and I was confused myself, do I need to continue this field or study other patients? But before I prove myself wrong or right, I want to do one thing more. So I did some studies that I will share with you today. This is the CMR data that we did. I'm a co-author on this paper. We looked in 41 patients who have right heart cath-defined pulmonary hypertension. And from our previous publication, we found if their transpulmonary gradient, which is the pressure drop across the pulmonary vascular bed, is elevated, if it is greater than 12, it's abnormal, less than 12 is normal, that parameter, that hemodynamic parameter, was independently predictor of survival in sickle cell patients. But we want to see if this elevation of transpulmonary gradient is associated with RV remodeling. So what we found is if their RV ejection fraction is impaired, then patients with sickle cell disease were having increased mortality. And the TPG and the RV ejection fraction less than 35 was associated with increased mortality. Again, this speaks out to what we said before. Patients with sickle cell or patients with other cause of pulmonary hypertension, they die due to RV failure. And this is data comes from the Netherlands. Whether your PPR at baseline or after therapy doesn't determine your survival. But if your RB adapts and improves, that's what it matters for survival in patients with pulmonary hypertension. So for the rest of the hemodynamic talk in sickle cell pulmonary hypertension, I'm going to start with a case of mine that I had the opportunity to treat him while he was alive. So this is KB. He's a 35-year-old African-American male. He suffered from sickle cell anemia, and his sickle cell complications were frequent recurrent pain crisis, priapism, and he suffered from pulmonary hypertension. On right heart catheterization, his mean pulmonary artery pressure was 44 millimeters of mercury. His pulmonary artery occlusion pressure was 12, which is normal. His cardiac output was 12.8 liters per minute. And his transpulmonary gradient, which is the difference between the mean pulmonary artery pressure and the pulmonary artery capillary wedge pressure, this is the pressure drop across the pulmonary vascular bed, was elevated. It was 32. Normal is less than 12. And his pulmonary vascular resistance was 2.5 Wood units. So as you can see from this hemodynamics, the pulmonary vascular resistance is a kind of borderline high. But when you look at his cardiac output is 12.8 liters per minute. This is not uncommon in sickle cell patients because of their inherent chronic anemia due to hemolysis. So his sudden death in 2010 happened under the circumstance that he was at home watching TV with his mother. He went upstairs to his bedroom, and his mother heard that he fell down. She heard a thud, and she went upstairs to check up on him. She said when she saw him, I knew he was dead. She consented for autopsy at the NIH, and this is his autopsy. As you can see here, it's the same slide that Dr. Kingslow showed you. You can only imagine how blood flows through this slit. You can see the whole intima, the media, and the adventitia was all proliferated. And this is not only on one section, it was diffused throughout his lungs. And this is, again, the plexogenic changes that we see in pulmonary hypertension, that they have this panvasculopathy. The intima, the media, and the adventitia proliferate like a cancer and block the lumen of the pulmonary artery. So, sudden death. Sudden death, I'm sure you guys, if you have taken patients with sickle cell disease, you have been called that your patient suddenly died last night. Sudden death is a common thing that we see in patients with sickle cell disease. We don't even know why they die suddenly. Partly is due to pulmonary hypertension, and partly due to unknown reasons that we all need to study. But sudden death is a very common thing in patients with pulmonary hypertension. This data comes from the Belgian registry. When they looked at 99 patients with pulmonary hypertension and they looked what are the causes of death, 32% of their patients died due to right heart failure, and 18% of their patients due to sudden death. And again, this was replicated in the NIH PAH registry. 47% of the patients were dying from right heart failure, and 26% of the patients were dying due to sudden death. So what do we know about right heart cath data in the sickle cell patient population? This is the first case series which was published in 1982 by this man. Of course, everybody knows this man. Dr. Francis Collins, in 1982, he was a chief resident at UNC Chapel Hill, and he was taking care of 3 patients of his own with sickle cell disease, and these patients were suffering with pulmonary hypertension. These patients were worked up very appropriately. They had right heart catheterization, and when they died, they had autopsy. So he compiled 3 of his patients, and he added another 3 patients who were reported in the literature. 2 of them had clinical history suggestive of pulmonary hypertension and autopsy data, and 1 of them had right heart cath and autopsy data as well. I believe one of the patients was reported by Dr. Ronald B. Scott. He is the legendary and sickle cell disease manager from Howard University College of Medicine. So he said that Dr. Francis Collins, in this paper, he emphasizes that pulmonary hypertension is a grave disease and sickle cell disease. And the management is not known and should be clearly stratified by right heart catheterization. So this is the first case series that was reported. Subsequently, this is one of the part slides from Dr. Francis Collins, which is similar to the patient of mine. Then subsequently, Dr. Oswaldo Castro, who is the professor emeritus at Howard University College of Medicine, he looked into all patients at Howard University Hospital who had sickle cell disease and underwent right heart catheterization. At that time, there were 34 patients. If they had pulmonary hypertension, they had worse survival. He had 20 patients with pulmonary hypertension, and 11 of his patients died, 55% died within 23 months of follow-up. So, as you can see, other than the mean pulmonary artery pressure, the whole hemodynamic, the whole complicated hemodynamic picture in sickle cell disease was not reported. So then this led us to in addition to the story that I told you before, this led us to dig much further to see if pulmonary hypertension is real in sickle cell disease, and if it happens, what are the hemodynamic subtypes? How does it relate into the overall survival of these patients? So the objective of our study was to characterize the hemodynamic phenotypes using highly rigorous standards. The highly rigorous standards are right heart cath. To date, right heart cath is the gold standard for diagnosing any patient with pulmonary hypertension, be it sickle cell disease or other cause of pulmonary hypertension. We also want to estimate the expected survival of patients with sickle cell disease pulmonary hypertension. We want to identify the hemodynamic predictors of mortality. We also want to know what are the clinical correlates of sickle cell-related pulmonary hypertension. So we defined pulmonary hypertension using the gold standard. You know what pulmonary hypertension is at this time. If they have mean pulmonary artery pressure greater or equal to 25 millimeters of mercury as rest, we call it pulmonary hypertension. If it is normal, no pulmonary hypertension. If they have pulmonary hypertension, where does the pulmonary hypertension occur in the pulmonary vascular bed? Does it occur in the arterial side of the pulmonary circulation, or it occurs in the pulmonary venous of the pulmonary circulation? Because this is very important how you manage your patients. So this is the data. When we analyzed the data, we had a total of 533 patients screened prospectively by echocardiography, both at the NIH and at Howard University Hospital. Out of this, 86 patients were fulfilling indication for right heart cath. Our indication for right heart cath is like any indication. If you have a patient with dyspnea, which is the most common symptom of pulmonary hypertension, if they have poor functional capacity, if they are walking less than 500 meters during a normal 6-walk distance, and if they have a dyspnea out of proportion to their underlying anemia, we subject them to do right heart catheterization. So at right heart cath, 56 of them had pulmonary hypertension. Again, out of the total screened cohort, pulmonary hypertension occurs in 11% in sickle cell disease. So again, if you recall to the previous slide that I showed you, when you do an echocardiography and when you do a right heart cath, the prevalence of pulmonary hypertension in this sickle cell disease population is different. But again, I want to remind you, pulmonary hypertension is an orphan disease. 11% of pulmonary hypertension in this population is still very high. So if they have pulmonary hypertension, what does their hemodynamics look like? This is the pulmonary hypertension. 56 patients had pulmonary hypertension out of the 86 patients. 30 patients didn't have pulmonary hypertension. If you look at the pulmonary hypertension hemodynamic profiles, you see the mean pulmonary artery pressure is 39 plus or minus 9 millimeters of mercury. Their wedge was slightly on the higher side. Their TPG was above 12 is high. Their cardiac output was very high. So by any metric, if you look in this hemodynamic parameters and compare them to other associated conditions with pulmonary hypertension, it looks very mild. But what I want to show you in this disease is also those patients with sickle cell disease, to begin with, they have a high cardiac output and they have low premorbid PVR because their pulmonary vascular bed has to dilate to accommodate 12 liters per minute as compared to 5 liters per minute in a non-sickle cell disease patient. So if they have pulmonary hypertension, out of those 11%, half of them have pulmonary arterial hypertension, half of them has venous hypertension. If they have pulmonary hypertension and you follow them over time, those patients with pulmonary hypertension have significantly higher mortality, 36% 6-year mortality compared to 13% in those who didn't have right heart cath, as well as 10% in those who didn't have pulmonary hypertension. So again, we have confirmed that if right heart cath defined pulmonary hypertension occurs in sickle cell disease, it's associated with increased mortality. In a Kaplan-Meier curve, in this figure, as you can see, the x-axis is uricinosis enrollment, and this is the y-axis is probability of survival. If you have pulmonary hypertension, you have bad prognosis compared to those with no pulmonary hypertension or those who didn't have any right heart cath, but they didn't have indication for right heart cath. One of the themes that recurs frequently is if patients with sickle cell disease age, they develop pulmonary hypertension, and we want to see if the survival differs if we if you put, instead of uricinosis enrollment, patients' death at age, patients' age at death. As you can see in this Kaplan-Meier curve, you see those patients with pulmonary hypertension, they die at any age faster than those without pulmonary hypertension. So clearly, yes, all of us die when we age, but age was not the driving factor. For the same age, a patient with sickle cell disease and pulmonary hypertension die prematurely. Then we look at what are the independent predictors of mortality from hemodynamic standpoint of in sickle cell pulmonary hypertension. We found systolic pulmonary artery pressure for every 10 millimeters of mercury increase, the hazard increased by 1.8. Pulmonary pulse pressure, mean pulmonary artery pressure, transpulmonary gradient, and PVR, all this independently predict increased mortality in sickle cell disease. And this is again a Kaplan-Meier curve. If you take the median, above median, mean PA pressure less than 25, greater than 25, you have increased hazard of death. Functional class, if you have functional class 3 or 4, compared to functional class 3, 1, or 2, you have increased mortality. If you have a transpulmonary gradient less than 12 compared to greater than 12, you have increased mortality. Oxygen saturation, importantly, if you have less than 9.7, you have increased mortality. Then what are then the pH-independent correlates? For you clinicians, when you take care of patients with sickle cell disease, what do you look for to suspect this patient might have pulmonary hypertension? And what we found is if they have elevated TRB and they have impaired 6-minute walk distance, this in this logistic regression model has a C-statistic of 8.6, so highly predictive of pulmonary hypertension. So something that you can take home if your patients are having dyspnea, sickle cell patients having dyspnea, but their dyspnea is out of proportion to their baseline hemoglobin, and if you do an echocardiogram and they are having elevated TRB, then you need to suspect this patient have pulmonary hypertension. And it's not, uncommon, it's not unusual to suspect it be it sickle cell disease or non-sickle cell patient, but again, we found this to be highly predictive of pulmonary hypertension. So this was translated into practice. In 2014, the American Thoracic Society published a practice guideline how to risk stratify, how to diagnose, risk stratify, and manage sickle cell patients with pulmonary hypertension. As you can see, this algorithm is very similar to what Dr. Polk and Dr. Kingslow showed you. So this is a rare disease. The symptoms are non-specific. We have to follow a guideline so that we don't miss it. And we learned enough from the previous presenters, if you diagnose it late, then the outcome is worse. So how do we follow to diagnose these patients early? We do screening echocardiography. If they are TRB, this is again the indirect estimate of pulmonary artery systolic pressure. If it is greater than 3, we take them directly to right heart catheterization. If it is between 2.5 and 2.9, you do two things. Either you do screen them very closely, you escalate their underlying therapy, or if you highly suspect this patient is having pulmonary hypertension and you don't want to delay the diagnosis, you do right heart cath. If they are TRB or their pulmonary artery systolic pressure is normal, then you follow them very closely again. So you do your right heart cath, then you see where the pressure is. If they have pulmonary hypertension, where is the pressure high? Is it in the pulmonary arterial bed, or is this in the in the pulmonary venous bed? So we call it precapillary pH when they have pulmonary arterial hypertension. So for sickle cell patients, if the mean is greater or equal to 25, the mean pulmonary artery occlusion pressure is normal. If the PVR is greater than 2 Wood units, it's considered to be pulmonary arterial hypertension. So this group of patients, you consider pH therapy, but they are very complex. If you don't have experience with sickle cell disease and managing sickle cell disease with pulmonary hypertension, it's better for you to refer them to a center where they manage these patients. And again, we have to manage every disease, other disease which can complicate pulmonary hypertension. And all the things that you see here were discussed by my previous colleagues. So in summary, pH by right heart cath occurs in 6 to 10 adults with sickle cell disease and is associated with high mortality. One thing that I didn't talk in before is that an acute increase in pulmonary artery pressure occurs during acute chest syndrome and severe vaso-occlusive crisis. And sometimes you don't diagnose them before they get acute chest syndrome and they can die suddenly with these complications. So acute RV failure in the setting of severe vaso-occlusive crisis and the acute chest syndrome is very common in sickle cell patients. So again, the hemodynamics, all pH is not the same. In sickle cell disease, you can get pulmonary hypertension, but the pulmonary hypertension, half of them is in the pulmonary arterial bed, half of it is in the pulmonary venous bed. So this emphasizes the need to do right heart catheterization to stratify these hemodynamic subtypes. And then when we look into survival, which type of pulmonary hypertension does predict survival in these patients? We found the hemodynamic parameters that I showed you collectively indicate that if they have precapillary pH, is the marker of increased mortality. Again, the 5-year survival in this patient is extremely low at 64%. So these studies have helped us to understand the complicated hemodynamic profile of these patients. These studies helped us to understand how pH impacts the survival and the functional capacity of these patients. But there are many answers, at least to my mind, there are so many questions that remain unanswered in these patients. So some of these questions, what is the underlying pathophysiology in sickle cell disease pH? Which biomarker suggests early pulmonary vascular disease in sickle cell disease? What is the relationship of pulmonary vascular disease and cardiac function in sickle cell disease pH? Do pH-targeted treatment improve outcomes in sickle cell disease? Does intensive sickle cell therapy, such as hydroxyurea, improve in those survival in those patients with pH with sickle cell disease? And what is the mechanism of this? These are some of the questions that need to be answered by you and me. And what is the future direction? I think the critical thing that we need to date is we don't have any therapy which was proven to be effective in sickle cell disease pH. And one side doesn't fit it all. We cannot borrow data from other patient populations and apply it to sickle cell disease. And I'll tell you one example. When they did in 2009 a randomized placebo-controlled trial on sickle cell patients called a walk-fast study, they gave them sildenafil or placebo. The study was terminated prematurely because sildenafil was causing more painful crisis and hospitalization in sickle cell disease. So we cannot borrow a study done in other patient populations to sickle cell disease. We need to study these patients, and to date, we don't have any randomized placebo-controlled trial completed in sickle cell disease populations. And this is, again, the urgent need that we need to do, all of us. So this is my talk on sickle cell disease. Now I'm going to change the gear to connective tissue disease-associated PAH and portal pulmonary hypertension. But I tell you, you have heard everything that you need to know from Dr. Polk and Dr. Kingslow on these two diseases. What I'm going to do is I'm going to re-emphasize what they said. But I don't have really new points on this. But when I was asked to give this talk, I was impressed by the organizers to select these two diseases in addition to sickle cell disease, connective tissue disease, and portal pulmonary hypertension. And I'm sure they are very knowledgeable people about the disease, because to date we know from the biggest registry, the REBEAL registry, which is a US-based registry from 50 centers, when they looked into the predictors of mortality across the board for all comers in patients with pulmonary hypertension, they found that chronic connective tissue-associated PAH and portal pulmonary hypertension were upfront as independent markers of mortality. So be it African-American patient, be it a white patient or Hispanic patient, if they have connective tissue disease-associated PAH or portal pulmonary hypertension, are at increased risk of death. So PAH related to connective tissue disease, as you can see here, all these connective tissue diseases will give you pulmonary hypertension: scleroderma, limited or diffuse form, SLE, Sjogren's, rheumatoid, mixed connective tissue. You can see pulmonary hypertension in these conditions, but what we see most commonly associated is the limited form of scleroderma. So in connective tissue disease, we'll see other slides in the coming slide. I'll show in the coming slide. Pulmonary hypertension and pulmonary fibrosis are the top causes of death in these patients. The pathology is similar to idiopathic PAH, but their survival is worse compared to IPAH. You have seen this slide. This slide comes from the REBEAL registry. Among associated conditions, the biggest harbinger of pulmonary hypertension is connective tissue disease. So this is a very important slide. If you look in the last 3 decades, you see that the yellow bar is scleroderma renal crisis. This has come dramatically down to less than 6%. But what you see increasing is pulmonary fibrosis, which is the pink bar, and the gray bar, pulmonary arterial hypertension. So those two diseases, these two pulmonary complications are the main causes of death in these patients. Again, all PH is not the same like sickle cell disease in connective tissue disease. And partly why they do poorly is because they have pulmonary arterial hypertension. Some of them have ILD-related pulmonary hypertension, but they also have pulmonary veno-occlusive disease, which is known to be associated with great survival. They can also have pulmonary venous hypertension due to left systolic, diastolic, or valvular disease, because this is a systemic disease. One thing that you can take home from this slide is if patients have autoantibody, anticentromere antibody, or the nuclear pattern staining in ANA, they tend to have pulmonary arterial hypertension. And especially in the African-American patients, we tend to see this nuclear pattern staining of the ANA. Again, you have seen this slide. If patients have impaired lung function, if you follow them over time, they develop pulmonary hypertension. So it's very important that we follow their lung function and their echoes closely. And this was, again, translated to practice that if patients with connective tissue disease comes to your clinic at diagnosis and yearly, you need to do echocardiography and PFT. Yeah, so again, predictors of mortality in patients with scleroderma. This is from the REBEAL registry. If you are a man aged greater than N60, if you have poor functional class, and if you have hypotension, blood pressure less than 110, you cannot call hypotension, but low blood pressure, and poor functional, poor walk less than 165 meters, and high PVR and high mean right atrial pressure, this independently increases your risk of death. So in summary, PAH secondary to connective tissue disease is a substantial cause of morbidity and mortality. Patients with systemic sclerosis are at risk developing PH and pH over time, and you need to follow them very closely. And survival with connective tissue disorders is not as good as compared with other PAH etiologies. So early diagnosis is the key. So just a couple of slides on portopulmonary hypertension. The pulmonary vascular consequences of hepatic dysfunction are hepatopulmonary syndrome and portopulmonary hypertension. These are two distinct pathophysiologic mechanisms which impact survival, especially transplant-related survival. The hepatopulmonary syndrome is intrapulmonary vascular dilatation. Portopulmonary hypertension is vascular obstruction. What you see with hepatopulmonary syndrome is oxygenation issue and hypoxemia. What we see with portopulmonary hypertension is hemodynamic issue and right heart failure. But it's not uncommon to see these two conditions occur on the same patient. When they occur, the outcome is fatal. So you already know the prevalence of portopulmonary hypertension. You have seen this slide before. I'm going to move on in the interest of time. But again, re-emphasize the need to do right heart cath. If you do right heart cath in these patients, you can't find pulmonary hypertension in some of them, but the pulmonary hypertension is due to high cardiac output or due to increased volume overload. We call it portopulmonary hypertension if they fulfill the criteria. Their resistance is high, their mean is high, and their weight is normal. So this is what you need to know from the REVEAL registry. Actually, this is from 7 US centers. Which group of patients do develop portopulmonary hypertension? We see it very commonly with female gender with autoimmune hepatitis. For unknown reasons, if they have hep C infection, it's protective. So if you have a patient with autoimmune hepatitis, screen them for portopulmonary hypertension. Yeah, so this is my last slide. Portopulmonary hypertension has significant impact for transplants. This data comes from 10 institutions, 10 transplant centers. They had 66 patients suffering from portopulmonary hypertension, and 45% of them were denied for transplant because of severity of their pulmonary hypertension. Mean pulmonary artery pressure of 53 and PVR of 614 dynes. 36 of them, 55, had orthotopic liver transplant, and 13 died, which is 36% mortality. 5 of them died during transplant surgery, 8 of them within 8 days post-transplant. And if the mean pulmonary artery pressure is greater than 35, the perioperative mortality was 60%. So this again was translated to practice guideline, the ASLD, adopted if any patient is if there is any plan to do a liver transplant, you need to screen them by echocardiography. If they have sign of pulmonary hypertension, then you need to do your right heart cath. If that patient is stable and her pressures are less than 35, that's only when they can undergo liver transplant. Otherwise, they will have very high perioperative mortality. So this is my last slide. This is the summary of portopulmonary hypertension. I thank you all for your attention. Yeah, sorry if I take more time. Yeah. Okay. All right, so this is the post-test. So Mary Brown, I don't know who gave her this name. I think Dr. Kingsley gave her this name. So Mary Brown is a 35-year-old African-American female with sickle cell disease who was taking birth control pills for the past 5 years. Her history revealed her mother died in her 40s with symptoms suggestive of pulmonary hypertension. She presents to you on her first visit following confirmation of her diagnosis at a PH specialty center and initiation of PH-specific therapy. You providing a collaborative care in cooperation with the PH specialty center due to the distance from the patient to the center. At diagnosis, her WHO functional class was class 3 symptoms, which means she gets dyspnea on suboptimal exercise. She walked 300 meters. Her BQ scan was a high probability. And her hemodynamics at right heart catheterization, her mean air pressure was 45. It's a moderately high. Right atrial pressure was 8. Her pulmonary artery occlusion pressure was 5, which is normal. And her cardiac output was 10 liters per minute. Her pulmonary vascular resistance was 4 Wood units. Which of the following should be part of your routine follow-up with a patient diagnosed with PAH? 1, 6-minute walk distance assessment. 2, echocardiography. 3, overnight oximetry. 4, BMP or NT-proBNP. 5, CBC, PTINR, and CAM7. 6, all of the above.
Hip, hip. Hip, hip.
Great. So almost all of you answered this question. We do all of the above. So what it means is when we treat our patients, we use goal-oriented therapy. Goal-oriented therapy is we aim to a goal where our patients to be before we initiate therapy. And on therapy, we also do all the steps that are listed here to see if we are reaching the goal. The goal of 6-minute walk test, the goal of functional class, the goal of proBNP, because these are independent markers of outcome in patients with sickle cell disease. So we want to walk our patients as normal as anybody, preferably more than 400 meters, because we know walking less than 400 meters is associated with poor outcome. Of course, echo, we want to see if their RV function has stabilized or has improved. We want to make sure our patients are not hypoxic, because unique to the pulmonary circulation, hypoxia causes elevation of pulmonary pressures. So at any time, day and night, their oxygen has to be at least 91 and above. NT-proBNP and BNP, this is an indirect marker of RV function or increased pressure. The RV facing increased pressure. And especially in sickle cell disease, proBNP is a marker of early mortality. Same with other patients with pulmonary hypertension. Because this patient was also on anticoagulation, she has a high probability BQ scan. You want to make sure that her INR is therapeutic. The goal of INR that we look for patients with pulmonary hypertension is 2.5 to 3. So the answer is right, all of the above. Next one. So I think this was discussed very well by Dr. Kingslow. It was not in my talk, but again, this patient appears to be doing very well because he managed her very well. And she says she wants to participate in a family event and asks you to travel by air. What would you advise her about air travel? In-flight oxygen supplementation is recommended for, number 1, only patients with full functional class 3 or 4. Those patients with arterial blood oxygen consistently less than 60 millimeters of mercury with oxygen flow rate to maintain an oxygen saturation of greater than 91% at all times, assuming the cabin pressurized to approximately 2,440 meters. 3, patients should avoid going to altitude greater than 1,500 to 2,000 meters without supplemental oxygen. 4, all of the above. 5, none of the above if the oxygen saturation is normal. Great. So yeah, again, hypoxia is a trigger of pressure elevation. In somebody who has already elevated pressures, a slight change in their oxygen can worsen the pressures and cause acute RV failure. Classically, as Dr. Kingslow told you, if your patients are at functional class 4, you wouldn't advise them to take any flight. They have to be stable. But at any time, the whole point of this question is that avoid any triggering or worsening factors, such as hypoxia. It's not only hypoxia, but when you take care of your patients, infection, dehydration, sepsis, hypovolemia, hypervolemia, all these things worsen the pressures and patient outcomes. But yeah, so the answer is all of the above. Thank you very much again for your attention. No, that's important. I knew it was late.
What we may have to do, because we've had such a tremendous amount of information shared, we may have to ask if the presenters would mind waiting towards the back of the room, because there's another presentation to come, and you can ask them questions there. I'd like to ask you to please fill out an evaluation of the presentation today. And lastly, please remember to leave two things. Remember to leave the audience response tools on the desk. They don't work on your TVs at home or satellites. I want to thank Dr. Polk. I want to thank Dr. Kingslow. I want to thank Dr. Mehari, because it was an excellent presentation today. Before we leave, we definitely want to thank our sponsors, Actelion Pharmaceuticals US, Gilead Sciences, and United Therapeutics. Thank you for being an excellent audience, and have a wonderful remainder of the conference. Thank you.